Jeff, we have all this. We have the drugs which promise, at least theoretically, to change the disease itself. So how impactful does the evidence need to be for you to warrant coverage? What do payers take into consideration when they look at this?
Well, the typical algorithm is it more efficacious than the standard of care, what we already have? Is it safer? And then the third thing we look at is cost. And then there's everything else, which is route of administration, utilization, those kind of things. So it's in that order. Even payers, even insurance companies look at efficacy and safety first. Mm-hmm. So these drugs will be covered because they're better and they're being studied on top of standard of care. So to me, the issue becomes what are the utilization management criteria that are put in place and who's the appropriate patient, everything we've been talking about, which again might be a moot point, because if physicians are not using these out of the chute for mild or to moderate, and there's a history of these other drugs being used in their system, then it'll shake out. But initially, because of the cost, we just need to make sure that in the first little while that we have these drugs, it fits the evidence that's available.
Does the mechanism of action of these drugs affect your willingness to pay for them?
Usually, no. It only does if we have multiple drugs with the same MOA, and then it comes down to contracting and pricing and things like that. But there's an old adage that I like: we tend to care if a drug works, not how it works. So we're going to look at the data. And so just because one works differently, if it's inferior, we're not going to pick it because it has a certain MOA. It comes down to the efficacy and safety of the drug.
But I totally agree with that. That we don't choose to cover a drug based on that. We're looking for the outcome. What does it do for the patient? The MOA does matter in the sense that you look at it in terms of potential drug interactions, and also what are rational drug combinations. Two drugs with the same mechanism of action, not generally a rational way of going about treating a patient, but it's non-steroidal and you add it to a steroidal. So that might make a difference for patients who need more therapy than just one or the other. So MOA matters, but not in our coverage decision, but basically some of the utilization management. We're really looking for here is efficacy.
I guess MOA might matter if the mechanism is such that it affects the natural course of the disease, so it is long-term better, even though short-term they have the same outcome, no?
Well, again, that's a reflection of the efficacy.
All right. Okay.
So I don't care how I get there. I care if I get there.
You care.
Well, it's an interesting part about MOA that starts to play in, and it's a little early to say because we don't have all the data yet. But when you think about, let's say, Th2 blockade, there are active programs now to look at, dupilumab for asthma, nasal polyps. Presumably, from a mechanism standpoint, it'll probably help for hay fever and all this other stuff. So, when you have these patients, like right now, who are on omalizumab for their asthma, and I'm putting them on cyclosporin, the two are not exactly cheap, and I don't like that combination so much. You have this potential value added of like a 2-for-1, so to speak, or a 3-for-1. So, while it's early on the efficacy, that's where MOA may play a role for some of these things, because there's some other biologics that may not have that same breadth in terms of covering that.
Note to self, note to viewers, he's not recommending you use these for nasal polyps.
No, I'm not. I think that's an interesting story to watch.
Sure.
We have to see the data.
Sure.
But if the data do come out and you get that indication for these drugs, that could be a great decision maker. Same idea with psoriasis, where the same treatment is being used for psoriasis cutaneously and the psoriatic arthritis, and you're getting that 2-for-1. No dermatologist in their right mind thought 20 years ago that they would be helping a patient's psoriatic arthritis, but they are now. And so you have this idea that you could really get a bunch of disorders treated with one agent and still have the precision without the side effects.
Okay, let me put it this way then. If we're going to take the insurers at their word, and why not? I like you. We like you. But it's not fair necessarily to make them the judge and the jury on all of this. And we get to a word that you use, Cheryl, which is stakeholders. You did use it. I heard you use it. How do we get this thing going? How do you get the shareholders, the stakeholders together to work together to measure real-world success of these drugs, and so give these guys and women some guidelines to say, look, here's what we think, and here's what we think you ought to be doing, here's what should be covered. How do you do that?
I think it goes back to something Ed said before. He said, you take that study population and you continue it out, and maybe it's phase 4 studies where we begin to monitor these patients basically in the real world. Coming out, looking at what happens over the natural history. And then as the stakeholders begin to venture out into the world, then we see how that works. Are we truly seeing that we're having better outcomes from a medical claims data perspective, are we having less doctor visits? Are we seeing, you know, more clear skin so that, and less itch time? So are those, you know, maybe antidepressants or sleep therapies, are we seeing less of those over time?
Well, I mean, how is that happening? I mean, this all sounds great, but how physically, mechanically, do you get all the stakeholders talking to all the other stakeholders? Do you have them get in a room and lock the door?
That's the tough part, because
I mean,
stakeholders.
nobody leaves until we figure out who gets these drugs.
We can't really do that.
Why not?
Well, because for one thing, the payers can't have this discussion together, because we can't have a discussion about how much we'll pay for something or whether we'll pay for something or not, because it violates antitrust laws, and we want to maintain those laws here. But one way to deal with this, and a great way to get these started, is for a professional society to create an evidence-based guideline. You know, they're the experts, right? And then they can also talk to patients, which helps with the risk-benefit and with asking patients what are the most, you know, important symptoms and problems to address and those sorts of things. But we take guidelines very, very seriously when they're evidence-based and they come from the appropriate professional society. That helps us a lot to get things done, and it's something that we can all start to talk about, even if we're not all in the same room talking about it.
Okay, so they just kicked the ball into your court, which is, we're helpless. Doc, give us some evidence-based guidelines. You willing to do that?
We're working on it. No, we are. You know, the American Academy of Dermatology recently put out, you know, a 4-part guideline series, which finished about a year or 2 ago. And, you know, it was a little early. And because we didn't have the biologics yet, we didn't have all these data, and we don't have FDA approval yet for any of these. So there needs to be a revision. There's a recognition of that. It's a costly and timely process, but you know, there are many advocates who are pushing that the AAD go that route and really get a revision. There's also a number of other international consensus groups that are working on position statements, et cetera, to try to provide a little more refinement to you know, the guidelines.
And I think that's going to be extremely helpful. I think there will be a lag time, though, as these couple of products the first wave gets approved, and then the guidelines will be updated. But I think going back, I think that while payers as a group of stakeholders can't get together and make the decision, each individual payer can look at a segment of its population and then do its own internal return on investment studies, its own internal sort of phase 4. What am I, because you have your own pharmacy claims, medical claims, crunch that, see what happens at the end, because that's where the real world analysis comes out.
Is that what you're
That's
doing
right.
now, Jeff?
So we do, depending on the disease state.
Okay.
I would argue, though, that it's rare that decisions are made on real-world retrospective data like that. A lot of it still comes from the randomized control trials. But I agree. The two words I'm going to throw into this pool, or this hat for this discussion, is data and risk. So collaboration on long-term studies, on who the appropriate patient is hugely important to see what some of those offsets are, and in terms of direct costs. And the other is risk. And if a drug doesn't work, who should be paying for that? There should be, I think, there should be some shared responsibility in that. And I'm not necessarily talking about an outcome-based contract. I'm not big fans of those because they're super hard to measure and operationalize. But some kind of discussion around shared risk.